Diabetes mellitus. Diagnosis and screening. One, which HbA1c value confirms a diagnosis of diabetes mellitus in non-pregnant adults? A, 5.7%, B, 6.0% to 6.5%, D, 7. Explanation. HbA1c 6.5% using a standardized assay confirms diagnosis if no interfering condition. P516. 2. Screening for type 1 diab in asymptomatic individuals is A, recommended every 3 years after age 40. B, not recommended. C, recommended in obese children. D, done with HbA1c testing. Explanation. No evidence-based intervention to prevent, delay T1DM. Thus, screening is not recommended. P516. 3. Which of the following is not a refactor for type 2 diabetes? A, age 40 years. B, acanthosis nigricans. C, family history of T2DM. D, high HDL cholesterol. Explanation. Low HDL is a risk factor. High HDL is protective. 4. Impaired fasting glucose IFG is defined as A, B, 5.6, 6.0 millimole per liters, C, 6.1 to 6.9 millimole per liter, D, 7.0 to 7.8 millimole. Explanation. IFG range 6.1 to 6.9 millimole per liter. 5. A random plasma glucose level diagnostic of diabetes is A, 8.5 millimole per liter, C, to 10 millimole, 11 millimole per liter. Explanation. A random glucose 11.1 millimole with symptoms is diagnostic. Classification and pathophysiology 6. Type 1 diabetes accounts for what PL diabetes cases in North America? A, 1 to 3%, B, 5 to 10%, C, 15 to 20%, D, 25 to 30%. Explanation. T1DM makes up about 5 to 10% of cases. P5 to 18. 7. Which is most characteristic of type 2 diabetes mellitus at presentation? A, ketoacidity and insulin resistance. C, childhood onset. D, autoantibodies to beta cells. Explanation. T2DM is strongly linked to obesity insulin resistance. P. 508. 8. Gestational diabetes is defined as A, diabetes diagnosed before 20 weeks of pregnancy. B, any gluco recognized during pregnancy. C, fasting glucose 7.0 millimole in pregnancy only. D, HbA1c 6.5% in first trimester. Explanation. GDM is onset recognition of glucose intolerance in pregnancy. 518. 9. Which drug class is most likely to cause dysglycemia? A, ACE inhibitors. B, statins. C, corticosteroids and blockers. Explanation. Corticosteroids are well known to worsen hyperglycemia. P, 519, Table 1. 10. MODY is best classified as A, autoimmune diabetes. B, a monogenic diabetes syndrome. C, gestational diabetes. D, secunda IC disease. Explanation. Maturity onset diabetes of the young. MODY equals monogenic syndrome. P, 518. Non-pharmacologic management. 11. The most effective lifestyle intervention for improving glycemic control is A, vitamin supplementation reduction, C, salt restriction, D, smoking cessation. Explanation. Weight loss improves insulin sensitivity and glycemic control. 12. Carbohydrate counting is essential for which patients? A, T2DM on metformin, B, T2DM on sulfonylureas, C, T1DM on insulin, D, all gestational deplenation. Carbohydrate counting is critical in T1DM for insulin adjustment. 517. 13. Self-monitoring of blood glucose is especially important in A, patients on diet alone, B, patients treated with insulin, C, patients with hypertension, D, Patty's. Explanation. SMBG is essential for insulin-treated patients. Have pharmacologic therapy. 14. First-line pharmacologic agent for most patients with T2DM is A, sulfonylurea, insulin, C, metformin, D, thiazolidinedione. Explanation. S, the recommended first-line drug in T2DM. P520, therapy section. 15. Insulin must be initiated at diagnosis in A, all obese T2DM patients, B, all T1DM patients, C, all patients with HbA1c percent, D, all patients with gestational diabetes. Explanation. Insulin is required from diagnosis in T1DM. P516. 16. A newly diagnosed T2DM patient with HbA1c of 7.8% should start with A, insulin, lifestyle modifications, C, sulfonylurea, D, combination insulin plus oral therapy. Explanation. HbA lifestyle first, then oral agents if no improvement in 2 to 3 months. 516. Which drug class can cause weight loss in T2DM? A, sulfonylureas, B, insulin, SGLT2 inhibitors, D, thiazolidinediones. Explanation. SGLT2 inhibitors promote glucosuria and weight loss. P52 effects. 18. Which is most associated with hypoglycemia risk? A, metformin, B, sulfonylureas, C, DPP4 inhibitors, D, SGLT2 inhibitors. Explanation. Sulfonylureas increase insulin secretion, risk of hypoglycemia. 19. Thiazolidinediones, e.g. pioglitazone, should be avoided: A. Hypertension, B. Heart failure, C. Dyslipidemia, D. Osteoarthritis.